welcome everyone, and thanks for your time today. My name is Paul Masterman. I'm a former head of communication in local government, but also now an independent consultant. And the good people of the Council's Advertising Network have asked me to lead today's webinar. This is the latest in a series of small but perfectly formed webinars sharing some sort of tasty snacks around communication advice and information from some of the country's top communicators. We've got Dave Roberts, who's head of communication at Salisbury NHS Foundation Trust, who I know well by reputation, and two people who I know personally very well and rate highly, Nikki Barton, who's strategic communications manager at Reading Borough Council, and Simon Jones, who's the executive director of communications at Westco. I don't know if you all realise, but we're in the middle of a major global health emergency, which got even more serious this week as we started, in this country at least, to roll out the new vaccine. And that's our subject for today. I mean, clearly it's been unprecedented, the kind of work that we've had to do over the last few months in terms of scale, size and impact. But I think we can still learn from good old-fashioned experience and expertise. And in our speakers this afternoon, we've got it in spades. So firstly, I just want to hand over to Dave Roberts, who's going to talk about his experience communicating the distribution of the HPV vaccine. Dave.
Yeah, hi, thanks very much indeed. So yes, people may well remember, it seems a long time ago now, but in 2010 or thereabouts, the HPV vaccine was approved for use across the United Kingdom, and then soon after that across other parts of the world. And we led the campaign to get it introduced through Parliament, but also through the public and making it acceptable. And I think I've been asked to look at the things that we learned from doing that. So I was doing that both for the industry and working with Joe's Cervical Cancer Trust, who was the very, very small cancer trust at the time, specialising in just cervical cancer support, working with one and a bit people out of a garage in Northamptonshire. So that's the kind of level we were starting with. And we went through the number of years from it being proved to be 100% effective against these strains of HPV, which was an incredible achievement for the scientists. But then how were we going to actually deliver that, and what did we learn which is useful for today's world? Well, I think the first thing we should touch on is, I know it's worrying a lot of my colleagues at the moment, is the anti-vax movement and those that are influenced by the anti-vax movement. The anti-vax movement themselves, they could be classified as being, headbangers in some kind of ways, and the fact that they're never going to be convinced of an alternative view. But they do have a disproportionate influence on the reluctant people. So what we learned about them was they focus on things that are genuine issues. So they focused on safety. They will always focus on safety. They will focus on efficacy. Does it work? They will focus on liberty. Are you going to make me take this vaccine? If I don't take this vaccine, am I going to be denied opportunities? So in this country, vaccines are voluntary and people can't ask about your medical and health records. So, this is an area which they always ask about, and they will just enlarge that. But it's those three things that are genuine and real concerns for everybody. So you have to tackle those concerns without feeding the beast of the anti-vax movement. And the fourth thing that they talk about will be equality. Do we all get it? Do we all get the same product? And again, that is very, very, very live today. So the issues haven't changed. In the 10 years since I was doing the HPV work to today, lots of the channels have changed, but the main issues haven't changed in how the anti-vax movement will function. So what did we do? Well, we focused on three things, really. We focused on informing people. So we informed people what the vaccine was coming, which is exactly what's happened over the last months here as well. We then educate them about the actual vaccine. So you talk about it, you talk about the details of it, you talk about the science behind it, you talk about the impact of it. And then you reassure them. And then you reassure them that it's all okay. that it's all fine, because there will be many trips along the way, especially when you're doing something as large as a full population vaccination program. So you've got to offer that reassurance. It is only once you've done all that that you can genuinely do the call to action. Now, everybody will respond differently. Some people will be informed, educated, and reassured all in one moment, and they'll be putting their hand up saying, vaccinate me. Other people will take a lot longer. They will do, and they'll need to be reassured a lot more before they go ahead with it. So from 2010 to 2020, they're the things that I've taken away. Safety, efficacy, liberty, equality are the issues that we have to confront. And the way we do that is by informing, educating, and reassuring. Thank you.
Thanks, Dave. Really useful. As I said at the beginning, I think whilst we're facing a pandemic of huge global economic, social, and health impact, the basic comms 101 of approaching any issue like this still applies. So you're informing, educating, reassuring, and a call to action. But what I will take away from what you were saying is that you probably invented a new theory, I guess, the headbanger theory of communication, but treating that with respect and identifying how that plays into people's genuine concerns about the impact of this vaccine on their health or their family's health. So thanks for that. I want to move on to Nikki Barton. Nikki used to work for Oxfam, and she's going to take us through how fundraising for emergencies at Oxfam are now influencing the way that her council communicates around COVID-19. Nikki.
Thanks very much, Paul. So yeah, my name's Nikki Barton, and as Paul said, I spent 10 years at Oxfam as a fundraiser, primarily for emergencies. And although I think people associate Oxfam with food quite a lot of the time, what I primarily specialise in is water, sanitation and public health. And coming into local government, I sort of wiped the slate clean and thought, right, I'm going to have to learn everything again, what this is all about. But actually what I found is my background in fundraising and the things I learned about public health have served really well during COVID. I was what's known as a direct marketing fundraiser. So everything that we did could be measured, and we tested, whether it was search marketing, email, whether it was direct mail, whatever we were doing, we tested. It was a bit easier with fundraising because you measured the pounds coming back in off of what you were doing. But what we've done at the council is use testing on our emails, and we've been doing subject line testing. So the top line on this graph shows you the actual number of opens that our emails are getting. We were really fortunate at the start of COVID. Our legal team agreed that because it was a public health emergency, we could combine all of the council's data. So we've been working with a database of about 100,000. So you can see right from the start, unsurprisingly, we were getting a really high open rate of about 70%. And then that dropped a bit to about sort of 40 to 50%. If you go here to sort of week 19, what you can see is we started doing subject line testing, and the purple line shows you the actual number of opens we got, and the green line shows you the number of opens we would have got if we'd used the lowest performing subject line. And the red line at the bottom shows you the extra contacts. So on average, an extra 5,000 people a week are opening our emails. And in the biggest week, 15,000 extra people are opening the emails. And just to describe what a subject line test is, we've got a whole database of 100,000. Before we send the email, we take 3 segments of 5,000. We give them each a subject line. We send it out. We give it 3 to 4 hours. And then when we see which of those is the best performing, we send the remaining 85,000 to the best performing. And that gives us between 5,000 to 15,000 additional opens for the whole file. Something else that's been a really interesting parallel is around public health. So the themes that are coming through are very similar to what I would have seen in an Oxfam emergency. So the incentives and disincentives that are needed to make people take the action that we want them to in terms of public health. So the image you can see on the far left there is soap, and that soap has a toy embedded in it. So this is a way of getting kids to wash their hands for longer in refugee camps, because they're washing their hands for longer because they want to get the toy out. The next one along, you can see a woman there and some children in the background. This is outside a toilet block in Zatari refugee camp in Jordan. Surprisingly, possibly in refugee camps, there's quite a big issue with vandalism. You often find people vandalise facilities out of the sort of anger and frustration of the situation they find themselves in. One of the things that Oxfam found that really worked was getting kids to paint tiles and pictures and have those embedded in the walls of the toilet blocks. People were less likely to vandalise facilities which have been personalised by children in their community. The third picture you can see there, this is about fear and cultural practice. So this is in Ebola in 2013, and this is people carrying bodies out of homes wearing full hazmat suits. And you can think back to the start of COVID when we were seeing nurses and doctors on the TV in kind of full protective gear, and that kind of fear around COVID and the need to take fear out of it, because it can prevent people acting. So what we found in Ebola was people weren't reporting deaths. They were keeping dead bodies in their homes because they were so scared of the process of people removing dead bodies. And the final picture there is teachers teaching children to wash hands. I think one of the main things I learned was you can never underestimate the extent to which people need to know the basics and need to have those basics repeated. And I think we've seen that with hands, face, face. You know, amazingly, people don't know how to wash their hands and don't do it properly and don't do it for long enough. And what we would do in Oxfam in emergency situations, which again I've seen us replicate in the UK, is, for example, talk about what song you might sing while you wash your hands to make it more catchy. So the kind of things we've done at the council, not rocket science, lots of people have done this, is make it personal, make it local. So how do I create that ownership, like the toilets and the tiles? How do I make this about my local community? What are the incentives? We're doing something for each other. You know, it's not this abstract national thing. And I know lots of people have done this, but you know, it's embedded in lots of learning from emergency charities over a long period of time. And I would recommend, if you get a chance, kind of going to the policy section of somewhere like Red Cross or Oxfam, and you'll find lots of stuff like this. The final thing is about voices. So that picture at the top there, this again is from Ebola. If you can imagine, there's a deadly pandemic. Like Ebola was 70% fatal, not kind of 1 to 3% fatal. Who do you want to talk to you about that? These are our education promoters in, this is in either Liberia or Sierra Leone. Not white expats from Oxford flying in, but local people talking to local people about the pandemic and how to tackle it. So we've been looking at the voices that we use. On the right here, you can see Nisha, who works at the local Royal Berks Hospital. She's Nepalese. We have a large Nepalese community in Reading, and we struggle sometimes to engage with them. So we've been using materials in their language from someone who is a health professional. And on the left, this is David Monday, our public health consultant. And amazingly, he did a 9-minute video of him just talking on Teams that we recorded, and it's had 9,000 views, with 30% of people watching it all the way to the end. And this is based on the insight that people trust frontline experts. They do want to hear from the frontline experts, not, sadly, sorry, councillors, not the councillors, not the managers, not the CEO. People trust people on the front line who they believe are seeing firsthand what's going on. So nurses, doctors, and public health. And so my final point is, don't underestimate yourself. You might think you don't know anything about the situation, but your past experience is valuable and might help you out.
3 things for me that come out of that quickly. One is around, don't rely on politicians to do your communication. And I think we probably got all views, we've all got views on that in terms of what's been happening over the last few months. Secondly, we must blooming learn from experience that the world has been through this before, through Ebola and SARS and so on, but we never seem to learn from that. And thirdly, this is about behaviour change, which is a good segue into Simon Jones from Westco, who's going to talk about applying health behaviour change techniques to the rollout of this vaccine. Simon.
Thanks, Paul, and good to see everybody. And really, some of my points kind of really do draw on and build on what others have said. And for me, that while the campaign is going to be run nationally, let's face it, the government is going to throw an awful lot of this in terms of what they're doing. It's really going to be won locally. And so what I mean by that is that, yes, the government's going to be pouring a lot of resources, but really it's the success is going to be on our ability to engage our local communities and to understand what some of those behaviours locally and what people are thinking and what their attitudes are to that. And so the starting point for me in terms of mapping that out in behaviours, really the most important bit is doing that research to understand local perceptions and attitudes to the vaccine and how that may differ from what the national research and indeed the global research is showing, which shows broadly is that the younger you are, the less likely you are to be convinced about the vaccine's merits, while we know there's significant confidence issues amongst BAME communities as well. So we need to draw on what is that local picture in each of our area. That can be done quickly, it can be done very cost effectively, you don't need big surveys, it can be done in days now digitally at very, very low cost. So I think that's the starting point for me. And the second bit is, once we understand those motivators and barriers and what they are locally, it's identifying those trusted local voices, those advocates, those ambassadors, because they're from those different communities based on what the data is showing, because they are going to be the most influential, far more than the national government figures or national voices. And indeed using that as well, because the third element for me is around challenging misinformation as well. I know it's not strictly behavioural, but a massive part of this campaign is going to be about challenging misinformation, which shows how generally the whole approach has to be about delivering this campaign in real time and using the data that shows what is working and what isn't working, based on what we're seeing in terms of how people are engaging with the campaign, how people are responding to the campaign, using all the data and insight at our disposal in order to be flexible, which brings me on to my final point, and probably the biggest point of all. Actually, it makes no sense, I think, for any council or indeed for any NHS to be doing this on our own. We have to work together, share the data, share all the sort of learning about what's working, what isn't working, share all the research and insight that we're drawing on our local communities. And so I really do support the idea of a kind of hub approach to this, to be able to share that learning, to be able to share the kind of some of the creative, some of the strategy, to be able to apply that locally, because the more that we join forces on this in terms of our local areas, the more effective we're going to be. So there's the offer at the end, really, and hopefully through we're already doing this locally in London with some of our client councils. They're working with JP to apply some of the behavioural barriers and motivators to look at how we can engage those communities using a kind of digital estate. And we'd love to be able to share some of that learning that has already been applied in terms of campaign development.
Great, thanks, Simon. It seems to me that the simple learnings from all three case studies, in a sense, demonstrate how we should generally communicate about anything in the universe, as it were. One is having very clear insight about the needs of your audience and how they respond to you. Secondly, use voices that are trusted in the community rather than necessarily the people with the job titles. Thirdly, challenge people's concerns, worries and misconceptions at their root and immediately and in real time. And fourthly, as Nikki indicated in her session, test, evaluate, learn from that data, as Simon said, and apply it in real time to the way that you're rolling out your campaigns. So thanks all for your time. Thanks to the speakers. I'm sure the speakers will be quite happy to answer questions or take emails over the next few days if you have questions. The girls and boys from CAN are also willing and able to give you advice and information and signpost some ideas. The last few months have been fast, furious, frightening, difficult, hard, but also quite rewarding and exciting. And we're good at this stuff as communicators, and we will prevail, I'm sure. Okay, thanks again for your time and see you soon.